Yeah, so I think we can start now. Good day, everyone. Today's topic is secondary open angle glaucoma, and I'm Dr. Olaniyi. I want to follow this outline. As we are all aware, glaucoma is a progressive optic neuropathy with characteristic optic nerve head excavation and specific visual field changes. Raised intraocular pressure is a major risk factor. It's actually a group of diseases, and they are subclassified into open angle, the angle closure types. Also, we have the developmental glaucomas. The open angle and angle closure types are subdivided into the primary and secondary secondary glaucomas. And today, our focus is on the secondary open angle glaucomas. And there's a list of them. We have the exfoliation or pseudo-exfoliation syndromes, pigment dispersion syndrome, steroid-induced glaucoma, lens-induced glaucoma, glaucoma after cataract surgery, post-traumatic glaucoma, glaucoma after intraocular hemorrhage, glaucoma after retinal detachment, glaucoma after vitrectomy, glaucoma with uveitis, and glaucoma secondary to intraocular tumors, glaucoma secondary to amyloidosis, or elevated EPISCLERAL venous pressures. Yeah, generally, the clinical features may be as follows. Generally, they are insidious in onset, maybe slowly or rapidly progressive, depending, and may be painless. The gonioscopic finding in this particular subgroup is open angle. And then they are usually unilateral, but maybe bilateral. And when they are bilateral, they may also be asymmetric, which may make them look unilateral. Usually, there may be, not usually now, but there may be a family history depending on the type, and then medical and surgical history may be contributory, just like history of trauma. Now, coming to specifically talk about the different types, we pick first of all the exfoliation or pseudo-exfoliation syndrome and glaucoma. This is the most common secondary open angle glaucoma worldwide, and in up to 15 to 40% of cases, it usually progresses to open angle glaucoma. The Lindbergh Society approximates that up to 80 million people may be affected worldwide. And the risk factors include increased age, exposure to ultraviolet radiation, living in high altitude, and in the genetics, the exon 1 of the LOXO1 gene has been implicated. For pseudo-exfoliation syndrome, generally, we talk about the exfoliation materials, and we look out for them, usually on the pupillary margin. But aside from that exfoliation material, we may also find trans-illumination of the iris, which is shown in this particular picture. Aside from that, when the patient with pseudo-exfoliation is dilated, we will find this target appearance. It's sometimes called the bullseye sign, in which there's a central translucent disc surrounded by a clear zone, and then another translucent area which is bounded by scalloped margin, as seen clearly in the second picture. The second picture also shows exfoliation materials on the margin of the pupil. In pseudo-exfoliation glaucoma, a patient may have pigment, as seen here. But as shown in the second picture, the pigmentation is usually not dense. It's not as homogeneous as we see in pigmentary glaucomas. And then they may also have sampliosis lines, which is an anterior deposition of pigment, a line of pigment deposit anterior to the Chauvis line. Now, in people with people age above 60 years, the prevalence of pseudo-exfoliation is as shown in this table. Various countries. Initially, it was found in the, it was thought to be more prevalent in the Scandinavian countries, but then it's been found that it's actually found in other parts of the world, including Africa. Now, pseudo-exfoliation in open angle glaucoma is estimated as follows in various studies across the world. And of note is that in South India, up to 26.7% of people that were previously labeled as having primary open angle glaucoma were found to have pseudo-exfoliation glaucoma. Now, looking at the prognosis of pseudo-exfoliation glaucoma, generally, they tend to have a higher mean intraocular pressure and higher intraocular pressure fluctuation. Also, the rate of conversion from ocular hypertensive to glaucoma is greater in them, up to 40% in a 10-year period compared to primary open angle glaucoma. And then they are usually found at presentation to have a higher IOP and worse disc and visual field damage at diagnosis. Medical failure rate is higher in them. That's medical management failure is higher in them, and they tend to require surgical intervention much more than POAGs. Also, progression to blindness is faster in pseudo-exfoliation glaucoma, and this implies that there is a need to actually diagnose and differentiate these patients so that their management can be more actively done. They tend to require intervention earlier, and when intervention is given, they tend to do well. These patients will respond, generally they may be started on medical management, but they also respond well to laser trabeculoplasty. Now, to come to the other group, pigmentary glaucomas. The pigmentary glaucomas are actually a result of dispersion of pigments in the anterior segment of the eye. They constitute 1 to 2.5% of glaucomas in Western countries, and they commonly have, they commonly occur starting from the 3rd and 4th decades. So the patients tend to be younger patients. And then some patients may have remittance from the 5th and 6th decade. So this means that some patients may present with normal IOP and no pigments in old age. What the implication of this is that some of these patients may be labeled as normal tension glaucoma, since they won't have any pigments in their angles, and then the IOP may be normal despite the fact that there's this damage. And some of them may actually be observed to be non-progressive. So they tend to be seen as if it's, they are normal tension glaucoma, but then they will be non-progressive because pigment has been cleared and the trabeculum has also recovered. These are actually a very small subset of pigmentary glaucoma patients. Usually, they will require medical treatment for IOP control, and then they respond also to laser trabeculoplasty, and some of them will eventually need surgery. So they require close follow-up and active intervention as at when required. Now, the pigmentary glaucoma is usually found to show darker pigmentation in eyes that are affected. And then the glaucomatous eye also has more pigmentation. And then the pigments tend to correlate to severity of the damage. But as mentioned, the pigmentation may clear with time. And usually, because of the convection of aqueous, the clearing of pigments will begin from the inferior quadrants, so that as time goes on, the pigment tend to be found in the superior quadrants, and then even the superior quadrants may be cleared with time and with age. And then we say for that small subset of patients with the recovery of trabeculum, IOP, intraocular pressure may be low. But these are just a small subset. What is found, this one just form a small subset. What is found more commonly is that they have wide fluctuation. The patients who are usually young patients, male patients, may tend to present with blurring blurring of vision, even with halos precipitated by activity. Some of these patients may be involved in sports like football, basketball, and they notice that the episodes occur after exercise. The first picture shows the concave peripheral iris observed in pigmentary glaucomas. And then the second picture shows a band of dense pigment, which is what is seen. Unlike in pseudo-exfoliation, where there may be a mixture, like salt and pepper kind of pigmentation. In pigmentary glaucoma, it's usually dense, as seen here. This picture, the first picture, shows iris transillumination defects, which is observed, it can be observed in pigmentary glaucomas. These slit defects are easier to observe in a dark room and in a dark adapted observer. They may be just as few as 1 or 2, but they can even be more than 70. Typically, they are in the periphery of the iris. The second picture shows Kunckenbach spindle, which is pigment deposited on, is formed by pigment deposits that is found on the endothelium, and they are in a spindle-shaped fashion. These pigments are actually engulfed by the endothelium, and they give rise to this appearance. Now, these both pictures here are pictures of transillumination, but even though they are both pictures of iris transillumination, we can see that there's a clear difference between the two. The first one represents the transillumination we are likely to find in pseudo-exfoliation glaucoma. This is usually around the pupil. It's usually around the pupil because the dispersion of iris in pseudo-exfoliation results from iridolenticular friction. Unlike in pigmentary glaucoma, where the slit defects are more peripheral, and this is because the dispersion of pigment is a result of iridozonular friction. So when from this transillumination and the location, one should be able to actually say, actually differentiate. So the signs, clinical signs that we may find in pigment dispersion glaucoma include these, but they are not always, they are not invariable, and they are not pathognomonic. We've seen the Kunckenbach spindle. We've seen Sampeolosis line, which is pigment deposited anterior to the Schwab's line. The Zentmeyer's ring is pigment deposited on the posterior capsule. And then the reverse pupillary block is what we may observe. It's like an accentuation of the concavity of the peripheral iris. This is thought to occur by the flow of aqueous into the anterior segment from the posterior segment, leading to exaggeration of that concavity and more pupillary block. So that's the disposition of the peripheral concavity can be seen in this ultrasonography picture. It actually shows for the same patient before and after YAC-PI. Now, the first picture, the concavity is there, but after YAC-PI, the iris has moved anteriorly. So the concavity is no longer there. In fact, there is now a little convexity. This explains why patients may actually have a drop in IOP from YAC-PI. That's pseudo pigment dispersion glaucoma patients may have a reduction in intraocular pressure following YAC-PI, but this is not usually sustained long enough. And these patients will usually require reduction in pressure with pressure lowering drops. And then some of them will eventually, of course, many of them do benefit also from laser trabeculoplasty. Some will eventually require trabeculectomy. Moving to the next group of secondary open angle glaucomas, we've come to steroid-induced glaucoma. This usually resembles primary open angle glaucoma. And typically you find raised IOP, intraocular pressure, decreased outflow facility, open angles, optic nerve cupping, and visual field loss. It is known that up to 5 to 6% of normal people will develop raised intraocular pressure after 4 to 6 weeks of topical dexamethasone. This group of people are referred to as steroid responders. And this steroid response is known to occur notwithstanding the route of administration of steroids. Some people will respond to steroid in inhalers given to asthmatics. Some will respond to steroid in steroid deposits used to treat vitreoretinal diseases. So the steroid response may occur notwithstanding the route of administration of the steroid. But the risk, the predisposed, people that are more predisposed to steroid response usually are those that have POAG, first degree relatives of people with POAG, diabetic patients, and high myopes. For them, treatment will be to stop the steroid. But stopping the steroid may not be feasible in some cases. Abrupt stop also will not be helpful. So usually the steroid there may be a need to change to a weaker steroid, or if in a situation where patient has been on steroid for a while, and there's a need to taper the steroid, the steroid may be replaced with a weaker steroid. For instance, if he's been on prednisolone, he may be changed to ephemoline, and then the tapering done with the weaker steroid. Once the steroid is withdrawn, usually the pressure comes down. But in a subset of these patients, no matter what is done by way of withdrawing on steroid, the pressure remains high. So right from the onset, they will require pressure lowering drops. And when they are still uncontrolled, some will actually require trabeculectomy. The next group of secondary glaucomas have lens-induced glaucomas. We have a list of 5, as you can see on your screen. The lower 2 actually cause pupillary block and then angle closure, secondary angle closure glaucoma. So they are not part, we won't be going into their details here. So for the first 3, we'll be going to some details. The first is the phacolytic glaucoma. In this case, there's leakage of lens protein from an intact lens capsule. The lens protein, which usually is high molecular weight protein that is obtained in elderly patients, because phacolytic glaucoma has been observed not to occur in pediatric cataracts, for instance. So it is thought that it's because with age, the lens proteins get altered into high molecular weight proteins. And so when they are they are liberated into the AC, even though the capsule is intact, the macrophages engulf them, and these macrophages that have engulfed the lens proteins now occlude the trabecular meshwork, leading to a reduction in outflow and a raise in intraocular pressure. So for these patients, there will be a need for IOP lowering drops, and then some may eventually require to have some AC washout. For lens particle glaucoma, the lens capsule is not intact, either because cataract surgery has been done or following trauma. So the lens material finds its way into the anterior chamber angle and occludes the trabeculum. The third is a for lens particle glaucoma also, it is thought that they may relieve on IOP lowering drops, but where there is no relief, they may need AC washout. The third is the phaco-antigenic. In this case, the eye becomes sensitized to its own antigen. So this stimulates a granulomatous inflammatory reaction that leads to occlusion of the trabeculum. This will definitely require treatment with IOP lowering drops, but very importantly, anti-inflammatory management. This picture, the first one, shows phacolytic glaucoma in a patient with Morgagnian cataract, whereas the second picture shows a large chunk of lens material in the anterior chamber in a patient with lens particle glaucoma. Now going to another group, the other group of secondary glaucomas. These pseudophakic or aphakic glaucoma usually occur after cataract surgery has been done, and they can be subclassified according to the time frame in which they present. So the first subcategory is those occurring within the first post-operative week, and they include pre-existing chronic open-angle glaucoma. That means in those kind of patients, glaucoma was there but was not noticed until after surgery. Of course, this means the patient will be managed just like a case of glaucoma. And then in another type is the alpha chymotrypsin-induced glaucoma. This used to be common in the days when ICCE was common, and it was a result of alpha chymotrypsin, which was injected to lyse the zonules. And so it is thought that it's the zonular fragments that occlude the trabecular meshwork. Another member of this group is the hyphema or debris following intraocular hemorrhage. Also, viscoelastic material, when it is not adequately washed out following cataract surgery, may eventually lead to a raise in intraocular pressure. It is known that under normal circumstances, the spike in pressure that occur from viscoelastic material will tend to peak around between 12 to 16 hours after the surgery. And then it actually subsides by 72 hours. So anything outside this time frame is not likely to be due to viscoelastic alone. But if it is due to viscoelastic, we expect in most cases will do well. We just they'll do well on IOP lowering medications like acetazolamide or even topical medications. There may also be idiopathic, that's unexplained pressure elevation within the first postoperative week. The next group is the intermediate onset group, in which there's it may be due to pre-existing chronic open glaucoma, as explained in the first group. It may also be a result of vitreous being present in the anterior chamber. In a case where there has been a PC rent and then vitreous was not cleared from the anterior chamber. In this kind of cases, there may be spontaneous relief because vitreous is expected to retract post-op. But in some cases where retraction does not occur or the IOP is still high, there may be a need to actually do vitrectomy to have relief in this case. So other causes in this category include hyphema, inflammation, lens particle glaucoma as explained, steroid-induced glaucoma as explained, and then ghost cell glaucoma. In this case, hemorrhage within the vitreous cavity generates red blood cells that get altered and migrate anteriorly into the anterior chamber and eventually turn into tan-colored particles that occlude the trabeculum. For this patient, they also respond to IOP-lowering medications, but if there's no relief on long term, they may eventually require AC washout. The third group following cataract surgery is those occurring as late onset, that is more than 2 months post-operatively. Again, maybe because of pre-existing chronic open-angle glaucoma. It may be ghost cell glaucoma. It may be ND-YAG capsulotomy that is responsible. In this case, the ND-YAG may generate particles or fragments from the capsule that occlude the trabeculum and impede outflow. So that means some of these patients, after initial treatment with IOP-lowering drops, if there's no relief, they may also benefit from AC washout. And then you may have glaucoma from late occurring hemorrhage following surgery, chronic inflammation, then pigment dispersion from intraocular lens may also be responsible. These cases, in the case of pigment dispersion from intraocular lens, it is thought that it is usually due to intraocular lens that is mobile, unusually mobile, maybe due to the size. That's when it's too small, the IOL and the haptic is small compared to the size of the eye, allowing it room to be freely mobile, or it may be due to the location. When some intraocular lenses are placed in the sulcus, they may lead to pigment dispersion. Then it may also be due to inversion of the intraocular lens. All these are things that may make the intraocular lens to have more contact with the iris. And it is the IOL iris friction that generates the pigment, which now occludes the trabeculum, leading to impeded outflow, raised intraocular pressure. So that means that for this patient, IOL exchange will be the definitive management. The last on this list is the UGH syndrome. It has been described in patients who have received iris fixated IOL. It has also been described in patients with PC IOL, even though it is more generally seen with AC IOL. These patients have iridocyclitis, they have raised intraocular pressure, and they have hyphema. The picture you see here is from patients with UGH syndrome. You can see the ACIOL that's in place. And then on the right, this gonioscopic view actually shows a loop, one limb of the ACIOL that has now found its way through the PI and is now posterior to the iris. Now, the next group of secondary open-angle glaucoma is those following trauma. This list you can see on your screen is not exhaustive, but these are quite common. These may be more common than others in this category. For the chemical bonds, especially when it is alkali bond, it is known to be associated with more raise in a greater raise in intraocular pressure, and it's thought to be because of the contraction of the sclera that happens as a result of the chemical injury. Generally, the management for this patient will be initial IOP lowering drops, together with the usual normal management for chemical injury. Now, the second here, the electric shock. Usually, it is known to give raised intraocular pressure, but the good thing is that it is self-limiting, and it's thought to be as a result of contraction of the extraocular muscles. For the radiation, post-radiation glaucoma, this also is thought to be a very bad prognostic feature when it occurs, because it means a lot of other damage has happened in that eye. Then the penetrating injury. This, particularly when there is retained intraocular foreign body is known to also be a cause of secondary open angle glaucoma. Most notable is when the retained intraocular foreign body is contains iron, and the iron now gets deposited on the trabeculum, causing damage and then impeded flow. In a similar fashion, intraocular foreign body containing copper may also liberate particles that will damage the trabeculum and lead to raised intraocular pressure. For these two cases, patient definitely will benefit from pressure lowering drops, and then pressure lowering drops. But then they may eventually need to have either vitrectomy to remove the retained foreign body, or that's if AC washout is found to be unhelpful. The last in this on this list, the blunt injury. This may occur following maybe injury during sports like football, cricket, tennis, and the impact leads to angle recession, which is actually the tear in the ciliary body between the longitudinal fibers and the circular fibers. And this leads to an occlusion of outflow, which causes pressure to build up in such eye. The thing to watch in this kind of patients is that in the acute phase, there may be no rise in pressure. But with time, pressure will build up, and most of the time, because it is insidious, patients may actually lose vision from glaucoma. So it becomes very important to educate patients that are coming in for management following blunt injury, that they will need lifelong follow-ups. And at this follow-up, what we will need to do is to have background glaucoma diagnostics done for them. That's pressures, visual field assessments, disc assessment, and then repeat as they come for follow-up, so that when the pressure is found to rise, then appropriate attention can be given. This is a picture showing patients with angle recession glaucoma. On gonioscopy, a recessed angle will appear as a widened ciliary body band. But what gives it out is that it's irregular. So there's a widening of ciliary body band apparently, but it will be irregular. And then especially when we compare with the unaffected eye, we'll be able to clinch the diagnosis. This second picture has angle recession, and also there's some blood in that angle. The next group of secondary open angle glaucomas is those occurring after intraocular hemorrhage. We've actually mentioned ghost cell glaucoma, hemolytic glaucoma. In this case, the red blood cells that are generated from this hemorrhage eventually get engulfed, get altered, and then engulfed by macrophages, which now occlude the trabeculum, leading to raised intraocular pressure. So these patients will require the IOP lowering drops, and then they may require vitrectomy if pressure is uncontrolled. Then the next on the list is hemosiderosis. In this case, the red blood cells generated from hemorrhage is altered, and then the iron in the heme particle is liberated. And this now causes damage and obstruction of the trabeculum in a similar fashion to siderosis that we discussed earlier on. Then hyphema, we are aware of that. Glaucoma following retinal detachment. Generally, we find that there's reduction in pressure when there's retinal detachment. And this reduction in pressure is what is commonly found. But in a small subset of patients, especially those that have retinomatogenius retinal detachment, they are found to have raised intraocular pressure with occurring from decreased outflow facility in the presence of open angle. This, they also have cells and flare, and this is referred to as the short syndrome. The interesting thing about this is that after the retinal detachment is repaired, the intraocular pressure comes down to normal. Now, glaucoma following vitrectomy. Up to 20 to 26% of eyes may develop glaucoma after vitrectomy. And this is thought to occur from either silicon or macrophages that are laden with silicon obstructing the trabeculum. For this reason, it's important to follow up these patients by doing applanation tonometry post-op. Not just immediate post-op, but on a long-term basis, they need to be followed up so that intervention can be offered as at when required. Now, indentation tonometry may not give accurate results in this patient because the sclera must have been incised in the course of vitrectomy. So the sclera is not an intact sclera. So indentation methods may not give reliable measurement. Now, for glaucoma with glaucoma secondary to uveitis, generally we see raised intraocular pressure when the uveitis is chronic, generally. And it is known that in the acute phase, there may even be ciliary shutdown. So what you expect is a reduction in pressure, sometimes even hypotony. Now, in this group, you have Fuchs heterochromic iridocyclitis, which tends to occur as mild chronic anterior uveitis with glaucoma and cataract, and is unilateral in 90% of cases. The onset is usually from the 3rd to 4th decade, and prevalence is equal in male and female gender. On examination, we tend to find round and stellate capes. This form of glaucoma is usually difficult to treat. On the long term, they may not respond adequately to medical management, and they often require surgical intervention. And several of them will eventually require glaucoma drainage device implant in order to have IOP control. In some cases, some specialists now offer them primary glaucoma drainage device implants to get control of pressure. Another member of this group is the glaucomatocyclitic crisis or Postner-Schlossman syndrome, which tends to occur in young patients and usually presents as unilateral, painful blurring of vision. It's usually recurrent. And then, even though unilateral, it may affect both eyes alternately. And the symptom is usually mild compared to the pressure that is found on examination, because the pressure may be as high as 40 to 60 millimeters of mercury. For them, treatment is anti-inflammatory medication. Now, the anti-inflammatory agents will be given to the patients whenever he has episodes of this condition. It doesn't have to be given to the patients as lifelong treatment. And the reason is we don't want the patient to be too exposed to steroids and the attendant complications thereof. Viral etiology is suspected in this case. Also, I must say that for Postner-Schlossman syndrome, patients may actually outgrow. Patients may outgrow this. In fact, the episodes are found to reduce with age. So patients tend to outgrow this condition. Other conditions that may be found or that may be responsible for glaucoma and uveitis as listed in this group. You have presbytitis, intratrabecular meshwork from various sources, infections like herpes simplex, and then juvenile rheumatoid arthritis, syphilis, sarcoidosis, HIV. Of course, for this, that means the definitive treatment will include IOP lowering medication and appropriate management of these conditions. Another group of secondary open-angle glaucoma is those occurring in relation to intraocular tumors. And among them, you have examples such as seen in this, depicted in these two pictures. The first one is a picture of a patient having glaucoma in iris melanoma. The second picture to the right of your screen is a case of uveal melanoma who also has glaucoma. For this case of uveal melanoma, we will please note the sentinel vessels on the sclera, which will give out that diagnosis. So other tumors may include metastasis from other sites, leukemia, lymphomas, and other benign lesions also may be responsible. Another group of secondary open-angle glaucoma is amyloidosis. Up to 25% of patients with hereditary amyloidosis develop glaucoma. And these eyes with amyloidosis may actually present with pigments on the trabecular meshwork or even pigments on corneal endothelium, mimicking pigmentary glaucoma. Some may present with white flecks on the iris or on the anterior lens capsule, mimicking pseudo-exfoliation glaucoma. But the clincher in this, in the amyloidosis will be histologic examination, in which amyloid is found in the trabecular meshwork. The treatment for this is like, the treatment for amyloidosis, glaucoma and amyloidosis is like primary open-angle glaucoma. However, their blebs tend to fail, again, because of deposition of amyloid within the bleb. So this next group is the elevated episcleral venous pressure. That's glaucoma resulting from elevated episcleral venous pressure. This may be a result from obstruction of venous drainage, such as when there is a superior vena cava obstruction, or it may be a result of arteriovenous fistula, ocular episcleral venous abnormalities like Sturge syndrome, thyroid eye disease, or idiopathic elevations. This picture here shows a patient with glaucoma from carotid cavernous fistula. This baby here is a case of Sturge. You can see the port wine stain, and then the engorged to your right. The second picture shows engorged episcleral veins. This patient, the management of these patients is actually quite challenging. Most often they require surgical intervention, and surgery may fail. That's trabeculectomy may fail, and they may eventually require glaucoma drainage implants. So in conclusion, when dealing with secondary open-angle glaucoma, we will have observed that detailed history and meticulous systemic and ocular examination is essential, because there's need to have a specific diagnosis in order to treat the patients accordingly. So maximal benefits will be from specific definitive treatment. So we may not have good outcome if we allow all these cases of secondary open angle glaucoma to be managed the way we manage primary open angle glaucoma. As a matter of fact, these cases of secondary open, these causes of secondary open angle glaucoma have to be excluded before we make a diagnosis of primary open angle glaucoma. So we may, if we like, see primary open angle glaucoma as a diagnosis of exclusion. And if we bear this in mind, then we'll be able to proactively manage patients with secondary open glaucomas, and then they will get more benefits from our treatment. At this point, I think we'll take questions. Questions? So we have a question here. Somebody is asking for is asking about reverse pupillary block in pigmentary glaucoma. Yes, in pigmentary glaucoma, what happens is that they tend to have, ab initio, they tend to have convex peripheral iris. So that means the iris periphery is bent backwards. Now, with repeated blinking, aqueous is forced from the posterior segment, that's from behind the iris, through the pupil into the anterior segment. And this raise in volume of aqueous and raise in pressure causes increase in the convexity, in the concavity of the iris. And worsens the pupillary block. So that when PI is done in such patients, creating a communication between the two segments, then there's a relief that now allows there's a relief of that pressure in the anterior segment, which now allows the iris to come forward and gives a relief of the pupillary block, and then the pressure is also reduced. But please note, as mentioned earlier, that this may not be the definitive management. Definitely is not the definitive management for pigmentary glaucoma. The definitive management will be an initial use of pressure lowering medications or laser trabeculoplasty. And then when patient is follow up, some patients may eventually require even trabeculectomy. So patient is followed according to which control, how control is obtained in his management. And it's only a small subset that will have a clearing of their pigments and recovery of the trabeculum, and then a lowering of the IOP, so that they, as they get followed up, may require less and less of IOP lowering medications. Now, to come to another question here, it says in pseudophakic and aphakic glaucomas, you were quiet about trabeculectomy. Is it contraindicated? No, it's not contraindicated. In fact, many of these patients will eventually, after the initial medical management, many of them may still need to have trabeculectomy. Another question here says, is it enough to do AC washout alone in lens particle glaucoma? In most cases, AC washout is enough in most cases. But like we know in secondary glaucomas, many of them, even after, let's say some of them, even after the offending or the trigger agent is removed, they still need to be followed up because some may require further intervention. We have managed cases of steroid-induced glaucoma in which the steroid is stopped, and then the eye pressure is still raised. And eventually, pressure is uncontrolled on medication, and patients still required trabeculectomy. So after AC washout, such patients need to be followed up. Then another question here says, two questions actually. It says, in treating Postner-Schlossman syndrome, how do we balance inflammation control with steroid-induced IOP spike? That is the treatment worsening the disease itself. Well, this will be, this is the reason why the patient will need to be followed up and monitored closely, so that when he starts responding to steroids, there may be a need to change to a weaker steroid, or even use non-steroidal anti-inflammatory medications. These patients definitely require anti-inflammatory treatment lifelong. But one precaution is that the patient must not be allowed to go home on a perpetual prescription of steroid, because that will most likely give him steroid-induced glaucoma. But intermittent or episodic treatment in accordance with episodes of the condition will actually see the patient through. And like we said, it's commoner in Postner-Schlossman, is commoner in young people, and the episodes reduce with age, and they tend to outgrow it. So I think that's a good thing about it, that with time, patient may be able to do without any steroids. Then the second question is, please, can you explain the role of AC washout as definitive treatment for lens-induced glaucomas versus cataract surgery versus triple procedure? Well, this question, there are so many sides to it. If you remember, if you recollect, the slide on lens-induced glaucoma had 5 causes on that list. There were 5 causes, and I said 2 of the causes, that is phacomorphic glaucoma, and the other cause, they will tend to they tend to cause secondary angle closure glaucoma, and so they are not included in this discussion. But for the causes that we discussed, like phacolytic glaucoma, in which case there is a intercapsule and then there's a leak of protein, that phacolytic glaucoma will require, first of all, a removal of that lens, a meticulous removal of the lens in cataract surgery will be definitive for that. But if you now have lens particle glaucoma following, you know, we said it could be due to, it could be secondary to trauma, or it can occur after cataract surgery. So that means that in that case, the cataract has been removed, but there are particles left. So for lens particle, those particles are to be washed out as definitive management. That's AC washout. And then you have the phaco-anaphylactic glaucoma, in which the patient is now reacting by, he has now developed a granulomatous inflammatory reaction to his own tissue. So in this case, that patient will require cataract surgery, not just AC washout. So we see that the treatment will depend on the cause. And for the lens-induced glaucoma, generally, if the lens is still there, part of this definitive management will be taken out to take out that lens. Are there other questions? Other questions? Well, it appears there are no more questions here. So thank you for your time and attention. Have a great day.